All right. Well, good morning and welcome to this morning's discussion of Psyfeld, the Muffin Tops. I want to welcome the new clerkship class to the end of the first week of the rotation. For those of you who have not yet participated in Psyfeld, what I would like to do is simply start out asking the group to unmute and let me know what you saw. What are some of the behaviors that you found interesting and want to discuss this morning? Any observation?
So when I was watching, it seemed there was a sort of thread between Jerry and George that they were sort of lying for external benefit. So though they weren't lying about a medical condition, you could think of it as sort of the same framework as Mullinger.
So give us some details with regard to these two characters, and now we're focused on Jerry and George. What was the plot summary here? What was the lie?
So regarding them, for George, he was lying about meeting a tourist with the sake of dating a woman. And Jerry, he was lying about being bare shaven for also dating a woman. And the lies sort of got out of control. They tried to continue as far as they could.
So let's talk about Jerry first. Jerry is brought into a situation in which he discloses something that isn't true. From a clinical perspective, what are some things going through your mind? I mean, forget the actual content of Jerry's self-report just for a second. Generally speaking, if someone were to actually present a clinical practice with a similar scenario where what they tell you as a physician is incongruent with what you could find, physical exam, history, diagnostic workup. Give me some of the ideas that are running through your head as a clinician. The first step is to ensure that you give your patient the benefit of the doubt, right? So at this point in the workup, what you have identified is that your patient's chief complaint, the very reason why they are seeing you, is not supported with the clinical evidence, specifically history, physical, diagnostic workup. At this point, you are still going to take your patient's self-report as true. That is, this is their experience that they're communicating. It's just that I haven't been able to find out what is resulting in that experience, whether it's unilateral blindness, whether it's left-sided paresis, whatever it might be. This is a domain referred to as the somatic symptom and related disorders. Okay, that's number one. You're dealing with a somatic symptom or related disorders. Disorder. And we'll get into what those related disorders are. On the other hand, if you then discover evidence that your patient has been deceitful, that they have knowingly and consciously lied to you, then you're moving away from the somatic symptom and related disorders. And now you're talking about two other conditions that are in your differential diagnosis. And they include factitious disorder and malingering. Right? So at least to start out, I want to make sure everyone understands the clinical scenarios that may play out here. Right? Somatic symptom and related disorders versus factitious versus malingering. In the former, the individual is not consciously deceiving you. However, for both factitious and malingering, they are knowingly lying to you. Now let's bring it back to Jerry. Jerry lies, and we know as an audience member that he's lying. So it does not appear that Jerry Seinfeld, the character, is struggling with a somatic symptom and related disorder. Now our differential is narrowed to either factitious disorder or the disorder formerly known as malingering. We'll still use the M word because it's easy to capture what we know or understand about this condition by using the older DSM-4 terminology. Why is it that he is lying with regard to his bare chest? Anybody?
I think he wanted to be better for his woman because I think I forgot her name, but she liked this dog that was hairless, and then he decided that he wanted to be more appealing to her.
Do we see any evidence of this misrepresentation, the chest here, prior to his dating?
Well, originally I thought that he began shading his chest hair because he noticed that it was a little bit, there was some asymmetry towards it. And then to accomplish the symmetry, he, eventually began shading all the hair in almost like a compulsive manner.
So this gets complicated now, and this is not unlike what clinicians have to struggle with in real life scenarios when we are trying to differentiate between a somatic symptom related disorder from either factitious or malingering. And even though we teach these subjects, these topics, as discrete mental disorders, the fact is that the lines between all three of them are very blurred. So they do end up in different chapters of the DSM and even psychology and psychiatry textbooks. But the fact of the matter is that the lines are really blurred with regard to what will readily define one versus the other. And clinicians have to be very careful that they understand not all the information is going to be provided them, especially at the initial psychiatric evaluation that would allow for a definitive diagnosis. People do not present as if they're on a shelf exam. All right, shelf exam after 4 sentences, we expect you to know the answer A, B, C, or D. That's not the way it works in clinical practice. So major teaching point here is that these are not necessarily discrete illnesses, at least not in the way they're taught. The lines are blurred, and people, while on shelf exams, we will give you a definitive because we do need to test your basic understanding of each of these conditions, but that's not the way things play out in real life. George, what's the reason why George lies? Again, is there any evidence? So he's trying to impress somebody new he meets. And so this, again, these are best friends since high school. So his motivation, at least on the surface, appears to parallel that of Jerry. Do we see George dressed as a tourist prior to meeting his girl?
Yeah. He had taken the clothes from the man that had asked him to wash his clothes, and then he kind of found himself in this situation where the woman he was attracted to thought he was a tourist, and then he had to keep lying to obtain that.
So not nearly as straightforward again. The other thing this brings up is how we actually are going to approach describing or even analyzing human behavior. Most of us now are at a point where we feel rather comfortable discussing the factors that contribute to human behavior, and that includes even abnormal human behavior, in a biopsychosocial model. I've brought this up several times. I know that I've even discussed this during the M2. One other way to formulate what is going on, that which you observe between these characters, is through the 3 Ps. What predisposes to such behavior, what precipitates it, and then what perpetuates it. We could see that the lines are blurred with regard to what perhaps predisposed and even precipitated George's behavior. But on the other hand, when he does meet the new woman, he continues doing what he's doing, and we can now begin to talk about what we see in this slice of time, this 30-minute episode called the Muffin Tops, with regard to what perpetuates George's behavior, specifically why he continues to do what he's doing pertaining to those clothes. So when we talk about perpetuating factors, they also will be biopsychosocial. And I want to focus on the middle of that. Psychological factors that are contributing to the perpetuation of George wearing those clothes. Any guess as to what topic we should be discussing now with regard to psychological factors perpetuating George's behavior? Probably behaviorism, right? Probably operant conditioning. I mean, George continues to wear those clothes. We have to identify that that clothes wearing behavior is strengthened. And it's strengthened because of something that his new girlfriend is giving to him. So what perpetuates George's behavior is going to be biopsychosocial, specifically from a psychological perspective. It's likely positive reinforcement. Positive, there is something added to the situation, his new girlfriend's attention. Reinforcement, it strengthens George's clothes-wearing behavior. So I think George, even though we start out thinking, and I agree, what is precipitating George's behavior looks to be consistent with malingering. But what perpetuates it, we can actually also include basic teachings in behaviorism, specifically operant conditioning. And the operant conditioning principle that I think we see at play here that perpetuates George's behavior is positive reinforcement. Negative reinforcement, we may as well just fill this grid out now. Negative reinforcement is when behavior is strengthened. Reinforcement always strengthens behavior. But instead of adding something positive, negative reinforcement is the strengthening of behavior, perhaps even clothes-wearing behavior, by removing something that is negative. Both of these contrast to punishment, in which behavior is weakened. If something is added to weaken behavior, positive punishment. If something is removed to weaken behavior, negative punishment. Right? So 2x2 rubric, positive and negative reinforcement, positive and negative punishment. Anything else before we move away from George and Jerry with regard to the Muffin Tops? How does this end for Jerry? It's one of the last scenes, was last 10 minutes of the show.
It's kind of comical. Oh, go ahead.
No, it's okay. He's just like outside, like scratching his chest vigorously because he had been like trying to hide that the hair was like coming in and making it itchy.
What's that an allusion to?
A wolf. He was like he was howling to the sky.
Yeah, right. So, I mean, we were not going to get away today with regard to whether the films we're going to discuss later or the Seinfeld episode we chose to discuss this morning without talking about some monsters, right? So there's a direct allusion here to the werewolf. And along those lines, there's a couple things I want to point out. Number one, with regard to the werewolf or even the wolfman, and we use those two terms interchangeably right now. Number one, there's this condition called the intermittent explosive disorder, in which individuals will report that they have this impulse that overcomes them, that they can't resist. And what that impulse is will define what impulse control disorder we're talking about. And for intermittent explosive disorder, it's rage, it's anger. Episodes of anger and rage that are beyond which an individual will deem appropriate given the level of stimulus. Okay, so the intermittent explosive disorder is one form of a larger group formerly known as the impulse control disorders, all of which are defined through this irresistible urge. Okay, the one thing I want to caution everybody about with regard to not only the intermittent explosive disorder, but other impulse control disorders, including kleptomania, pyromania, and trichotillomania, which was formerly in the impulse control disorders chapter. It has since been moved out, and it's thought to be on a continuum with obsessive compulsive disorder. But in either case, we always have to rule out that the impulsivity is not due to a larger mental disorder. And even in the original, with regard to the Wolfman and its remake, Del Toro, more recently, there is an allusion, a rather strong allusion to bipolar affective disorder. Bipolar disorder is defined through episodes of mania. If you've ever experienced mania before, your single best diagnosis is bipolar 1. Now, like any disorder, bipolar 1 must always address whether or not that episode of mania is not due to the direct and physiologic effects of a substance or an underlying medical condition. That goes for any mental disorder. In addition, the only mental illness that the clinician must consider in someone who has experienced mania is schizoaffective disorder of bipolar type. That is the only mental disorder that takes precedent over bipolar 1. Otherwise, if you've experienced mania, you have bipolar 1. And the Wolfman or the werewolf may actually have experienced mania. Their impulsivity may be in the context of a discrete manic episode. So there's always that discussion to be had when analyzing this monster. Is it a bipolar 1 illness versus an impulse control disorder called the intermittent explosive disorder? And I think that's what Jerry's last 10 minutes of the Muffin Tops allows us to discuss. Before we move away from these two and discuss other characters that you want to bring up this morning, I also want to make a comment about one of these other related disorders in the context of somebody presenting to you with a chief complaint for which no underlying physical or organic etiology can be found. One of the conditions we said is somatic symptom disorder. One of the related disorders that I want to mention is conversion disorder. I'd like you to think of conversion disorder as a variant of somatic symptom disorder. Somatic symptom disorder is simply one or more somatic complaints for which no underlying physical cause can be found. It's a real straightforward definition. The second part, though, is something you have to remember. When defining somatic symptom disorder, those somatic complaints cannot be voluntary motor and or sensory deficit. Because if your patient presents with deficits in voluntary motor or sensory function, while I think number one in your differential is going to be somatic symptom disorder, there's a specific type that garners its own diagnosis or diagnostic label, and that's conversion disorder, right? Conversion disorder. Now, there's an infamous case of conversion in which an individual loses his ability to speak. Well, we could talk about this later today. I don't want to take too much more time up with regard to the half an hour we have this morning, but that's the case of Michael Myers, right? So that's Deborah Hill's and John Carpenter's Halloween. And we have another monster that loses his capacity to speak upon the death of his older sister, which is the opening scene in the 1978 slasher classic Halloween. So for those of you who have seen the movie, we could discuss this further between morning and afternoon rounds today. So I just wanted to mention that before we moved away from Jerry and George. Any other characters you'd like to identify, interesting behaviors that you observed in the Muffin Tops?
I thought Kramer was interesting. To me, it seemed like he almost had like a histrionic personality disorder. He seemed like he wanted to kind of be the center of attention. He was trying to sign the books. And he was like putting on like a tour, like a bus tour. And I thought all his behavior was like really theatrical and kind of focused on him. So that kind of gave me like that vibe.
Yeah. So in identifying the behaviors that you did, taking that bus tour, the book signing, certainly Kramer is setting himself up to be the center of attention. And anytime we hear that, and that type of behavior is clinically significant, we have to consider the histrionic personality disorder. individuals with histrionic personality have usually at the core of their etiology profoundly poor self-esteem. And Kramer's name was actually taken away from him. That is, who he was sold. And what a great job by Larry David of creating a situation that lends to extremely poor self-esteem. And that's almost the definition of poor self-esteem, is not really understanding or feeling comfortable with who you are. And how could Kramer, since he sold who he is to Peterman? So I thought that was a real interesting and unique way to bring across this idea of poor self-esteem. He lost who he was because who he was sold. So now you have someone with profoundly poor self-esteem. We identify this really as the etiology of multiple personality disorders, including the histrionic personality disorder. And what will differentiate one from the other are the cardinal features of that disorder. And even though we're not going to go through the personality disorders at this moment, I will ask you, certainly over the 4 weeks of your clerkship, I want you to consider not only learning the personality disorders with regard to the 3 groups or clusters, but taking a second step and beginning to reorganize them into 2 columns. One column that actually adheres to a cardinal characteristic or trait, and those that don't. Because what you'll recognize is that number one, the vast majority will be in that proverbial column A, that they will adhere to a cardinal trait. And then number two, once you understand that cardinal trait, recognizing the DSM criteria that are sure to show up in a clinical vignette on a shelf exam is that much easier. Much easier than memorizing or reviewing the criteria themselves. So know that cardinal trait, hammer that out, and all of a sudden those criteria simply morph into characteristics or examples of that cardinal feature. And that cardinal feature for the histrionic personality is the individual who's very dramatic and needs to be the center of attention. And I think that's going to be high in our differential trying to explain the behavior of Kramer in the Muffin Tops. Before I leave Kramer's histrionic traits, rule out personality disorder, I want to identify 5 or 6 things. There are several that the clinician must address in order to diagnose any personality disorder. I believe there's 6 of them, right? And it's probably worth discussing them the first week of your clerkship, because every time any personality disorder comes up for discussion in our differential diagnosis, we have to review these 6 again and again and again. So with regard to teaching, it's probably good to discuss them right now and then agree that they will apply to every personality disorder that we're going to discuss through the remaining 4 weeks of your psychiatry clerkship and then the rest of your medical school and residency career. And if you go into psychiatry, even your career. So what are those 6 things that we have to address in working up a personality disorder?
Is one of them that you have to rule out, like you said, medical or a substance cause of the behavior personality changes?
So ruling out substance-induced personality change versus an underlying medical condition, absolutely. That's 1 and 2. We have 4 more to go.
Whether the behavior has been consistent across like a large portion of their life.
Perfect. It's got to be stable, right? Our personalities are stable, so that means our personality disorders are going to be stable too over time. Excellent. 3 more.
It needs to interfere with daily functioning.
Perfect. 2 more. Not only must it be stable over time, but it must be pervasive, crossing multiple social settings at any point in time, right? So if you are being histrionic when you're on wards, when you're on rounds, but when you leave the hospital, you are quote unquote a different person, you are not, you do not have the histrionic personality disorder. I'm not sure what you're doing, but it's not histrionic personality disorder, right? So not only stable over time, but pervasive, crossing multiple social settings at any point in time. And then the final one is that similar to ruling out substance-induced and an underlying medical condition, we must also make sure that there is no active mental disorder that would explain the change in personality either, right? So we should reserve any clinical judgment on who a person is during acute psychiatric illness, exacerbation of schizophrenia, or an exacerbation of mania, right? We have to reserve our clinical judgment until the primary mental disorder is addressed, right? So they're your 6, and they will apply for every one of the personality disorders. Any other characters you'd like to discuss? We're kind of coming up to 9:30, and at this point, I'll even ask the undergraduates if they want to unmute. You feel free to ask any questions in the remaining minutes we have. Everybody's okay? No further questions? All right, well, we'll then hold it here. That will complete our discussion on the Muffin Tops. Covered a good amount of material today. After rounds today, we'll be talking about Hoodwinked. We'll be back on Periscope discussing Little Red Riding Hood and Hoodwinked on Periscope, probably more towards 12:30 today. We'll catch everybody back then. Thank you.